Hello, I'm James, and in this video, we are diving into rhabdomyolysis. It sounds complicated, but at its core, it's just what happens when your muscles stage a biochemical protest and start leaking their contents into the bloodstream. Let's make this simple and clinically relevant. This is ideal for medical students, nurses, and healthcare professionals, as well as anybody curious about medical knowledge. Sounds like your kind of learning, so don't forget to subscribe. Your kidneys will thank you later. To really understand rhabdomyolysis, we need to step back for a moment into the muscle cell and appreciate that muscle contraction is not for free. It's an energy-intensive process, and ions, especially calcium, play the starring role. Think of calcium as the key that unlocks muscle contraction. When it floods into the intracellular compartment of the muscle cells, contraction happens. When it is pumped out, relaxation follows. So controlled calcium movement is essential, right? To keep things running smoothly, muscle cells rely on several ion transporters. One you have probably memorized is the sodium potassium ATPase. Okay, the one that kicks out three sodiums and then brings in two potassiums. But today, let's highlight a lesser celebrated but critical player, the sodium calcium exchanger. Now, as the name suggests, this exchanger swaps calciums and sodiums across the membrane, and its direction depends on cellular environment. I want you to take a look in its forward mode right here. Okay, it pushes calciums out, and then in exchange for sodiums. This helps the muscle to relax. In the reverse mode, the exchanger pulls in calciums while sodium exits, which can ramp up intracellular calciums and potentially contribute to muscle damage under stress. So when these ion channels and exchanges are disrupted, as seen in rhabdomyolysis, cellular injury may occur. So understanding ion regulation, especially of calciums and sodium, isn't just academic, but foundational. The muscle cell is tightly regulated, and when that balance tips, the consequences can be severe. Now, just to connect the dots, I am briefly showing you the myofibril structure, and it is not to dive deep into muscle contraction physiology, but to remind us that ATPs are absolutely essential for muscle function. Moreover, in rhabdomyolysis, when ATPs are depleted, things go down the hill pretty fast. Here's a basic recall. Calciums binds to troponins, which then shifts tropomyosin, okay, and exposes the binding site. The myosin heads in their high energy states binds to actin and form a cross bridge. Now in this simplified state right here, you can see that ATP binds to the myosin head and it causes the cross bridge to detach, essentially resetting the system. Without ATP, the myosin head cannot release and prolonged contractions or rigidity can occur. Now here's the link to rhabdomyolysis. Excessive intracellular calciums, as you can see, often from disrupted ion channel or the exchanges we mentioned, sodium calcium exchanges, it triggers a continuous ATP use. Eventually, the cell runs out of ATP. That leads to a membrane instability, enzyme activation, and even cell death. Now, let's focus on what happens inside the muscle during rhabdomyolysis. So there is a dysfunction of the sodium-calcium exchanger, as previously mentioned, which results in increased influx of sodiums and calciums in the intracellular compartment. Okay? Excess intracellular calcium leads to an increased ATP consumption, eventually causing energy crisis within the cell. With ATPs being depleted, the muscle cell loses its ability to maintain homeostasis and injury accelerates. Take a closer look at an affected cell in rhabdomyolysis. So calciums, as we see, is in excess, and it can actually activate enzymes such as phospholipase and protease, which starts to tear down the cell membrane from within. Okay, meanwhile, calcium's leaving the extracellular compartment to rush into the damaged cells can also cause hypocalcemia. So it's not uncommon to see decreased calcium levels, which is another systemic concern. Now, as sodiums continue to flood into the muscle cells, it comes along with water, right? And so the cell swells up and further destabilizes the cell membrane. And when water is moving into the cell, certainly this will lead to plasma volume depletion as well. In response, the body activates the renin, angiotensin, aldosterone system, as well as arginine vasopressin pathways to compensate for fluid loss. So, compensatory perfusion right there brings in white blood cells, okay, along with a mix of cytokines and free radicals, which basically show up to trash what's left of the cell membrane. Eventually, the membrane integrity is lost and the cell spills its contents into the bloodstream. So we are talking about myoglobin, creatine phosphokinase, potassiums, phosphates, AST, lactate dehydrogenase, aldolase enzymes, and even uric acids. So the toxic cocktail contributes to systemic complications, especially acute kidney injury, electrolyte imbalances, and multi-organ stress. Once muscle cells break down, myoglobin escapes into the bloodstream and freely passes through the glomerular filtration barrier. Okay? Inside the nephron, damaged tubular cells try to reabsorb myoglobin, especially this is avid in acidic environment, which ironically makes it more toxic. So it's like trying to clean up a spill with fire instead of a mop. Vasoconstriction adds fuel to the fire, reducing renal blood flow, worsening ischemia and pushing the kidney toward acute tubular necrosis. On urinalysis, you might see a dark tea-colored, reddish-brown, or amber urine thanks to myoglobin. But don't rely on the classic look, it's not always textbook. And here's the catch. A urine dipstick may light up positive for blood, but it can't tell the difference between blood and myoglobin. That's where microscopic urinalysis comes in, to check for the actual red blood cells and rule out hematuria. So just because your dipstick says blood doesn't mean that the patient is bleeding. Sometimes it's just myoglobin. A hallmark investigation is creatine phosphokinase. Levels typically exceed 4 to 5 times the upper limit of normal. It may rise within some few hours after injury, maybe 2 to 12 hours, and then peaks around 3 to 5 days. Other biochemical investigations include an elevated LDH, AST, aldolase, and uric acids as a result of the muscle breakdown. Electrolyte abnormalities include excessive potassiums, hyperphosphatemia, and a decreased calciums. So this may lead to a QT prolongation on an electrocardiogram. Note that late hypercalcemia, by that I mean excessive calciums, okay, can occur in trauma-related cases, hence use caution with calcium replacement. A renal function test is essential to assess for acute kidney injury. Electrocardiograms can help detect arrhythmias, in this case hyperkalemia or hypocalcemia. Complete blood count with differential C-reactive protein ESR may be abnormal, but it is non-specific and useful in assessing inflammation or infection. Additional tests may include chest x-ray to evaluate complications or underlying causes, blood cultures if sepsis is suspected, compartment pressure monitoring if compartment syndrome is a concern. So further investigations may be needed based on clinical context. Treatment. So you need to identify and treat the underlying cause. That's essential. Secondly, you try to prevent acute kidney injury through aggressive IV hydration. Okay, normal saline is commonly used, but it may cause acidosis, which can actually worsen tubular injury. So you need to take note of that. Ringer's lactate can also be used cautiously, but note that Ringer's has a theoretical potassium load. Dextrose may also be added for caloric support and to reduce the risk of hyperkalemia. You would also like to enhance myoglobin clearance through urine alkalinization, example with bicarbonates to prevent what? Myoglobin and uric acid precipitation. Okay, mannitol may also be used to promote diuresis, especially in crush injuries, but only after ensuring adequate urine output. You need to correct the electrolyte abnormalities, that is, manage hyperkalemia, hypocalcemia, and hyperphosphatemia carefully. Avoid routine calcium unless symptomatic due to a risk of late hypercalcemia, especially in trauma induced rhabdomyolysis. You need to monitor closely. By that I mean you need to track the urine output, renal function, as well as electrolytes. Watch for and treat complications like sepsis, compartment syndrome, DIC, or a malignant hyperthermia as needed. Management should be individualized, so that is going to be done with close monitoring and supportive care, which is central to improving the outcome. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.